Can you hear us?
Yes, go right ahead. Hold on, you just muted yourself. Please unmute.
Try it again.
I think we're good
Can you
now.
hear us?
Yes, good to go now.
Excellent. Thank you, Joe. Okay. Well, I was in the process of welcoming you on this really gorgeous summer afternoon. And in the spirit of the season and summer and vacations, we are going to be taking our own little road trip today, and our destination is person-centered care for behavioral health. But also in the spirit of the season, as we know that summer means construction in Minnesota, and we run into roadblocks. Well, Amanda and I ran into our own roadblock this morning as we were preparing this for the presentation, and unfortunately, we don't have our most recent version of the PowerPoint slides. This is an earlier version that you're going to be seeing, and so it's not quite as polished as the final version. So we're going to turn it into a road trip game called I Spy, and if you can spot the two typos in the PowerPoint, we'll tell you what they are at the end, but see if you can spot them. So a little bit of introduction. I am Julie Rehoboth. I am the Director of Training and one of the founders of the center, and I'm very pleased today to be presenting with
Amanda. My name is Amanda Talon. I'm a licensed graduate social worker and a licensed alcohol and drug counselor. I have held various clinical and research roles, and I'm really excited to be here today presenting on person-centered care. This is a topic that I care greatly about.
And Amanda has really been instrumental in helping the center learn more about what Minnesota defines as person-centered care. And we also wanted, before we take off on our own road trip with you today, give you a little bit of sense of our journey with person-centered care and kind of what got us here to today. So our sponsor, the Department of Human Services Mental Health Division, asked us about a year ago to do a comparison, a crosswalk between person-centered care, person-centered principles, and illness management and recovery, which is a practice model, an intervention model that we do a lot with here in the center. We have a great deal of expertise and train around that, and it is a requirement for some providers in Minnesota to use IMR. And so they were really interested in hearing about the intersection between person-centered care and IMR. And Amanda did a lot of research looking at peer-reviewed materials, various books, and then we want to do a shout-out to the Institute for Community Integration, ICI, here at the University of Minnesota, that were just incredibly generous, sharing their time and expertise with us to share what they know about person-centered care so that we could do this crosswalk and comparison. And so what you're going to be traveling with us today through is what we've learned, but truly a very brief overview of that. Sorry, we're still getting used to the system here. Okay. What's going to be happening today, because we only have 50 minutes with you, and really to do this justice, we would need a couple of days. It's that, the topic is that dense and that robust. So we are not going to be diving deeply today. Instead, we're going to be getting kind of the surface look at what person-centered planning or person-centered principles and person-centered care is, and really looking at just a few of the central principles and some of the tools that can go along with that.
So our objectives for the presentation today are to distinguish between person-centered care and the more traditional behavioral health treatment approaches. As Julie mentioned, we're going to be identifying several core principles of person-centered care. We're also going to be providing an overview of person-centered treatment planning. And as Julie mentioned even earlier, we're going to be discussing how IMR, illness management and recovery, fits nicely with person-centered care. And lastly, we're going to be discussing next steps and moving forward with respect to person-centered care and the behavioral health workforce.
There we go.
Okay.
Oh, no. Now we have to go back. The system's a little sticky this morning. There we go.
Okay, so as you may have noticed on our first slide, we posed the question, are we there yet, with respect to person-centered care and the behavioral health field? And I think we can say, generally speaking, we haven't yet quite arrived. There are absolutely some practitioners and specific agencies doing an amazing job with respect to implementing person-centered principles and person-centered care, but as a whole, we do believe that we have a ways to go. And there definitely are some roadblocks at place with respect to why agencies and providers may not be implementing person-centered principles and person-centered care at the rate that we would want to. Some of these roadblocks include possibly not knowing what person-centered care is, or limited views on who person-centered care is for, and there are definitely some real system barriers at play with respect to implementation of person-centered care.
So one of the potential misconceptions around person-centered care and where people may think they're doing more of it than they are is because of our own graduate school training. I know, speaking for myself, that when I hear person-centered care, I immediately think of the dear Carl Rogers, because that was the foundation for our clinical practice. And that we were really taught that for individuals to be able to grow and to change, that they needed an environment of genuine acceptance and empathy. And of course, this is considered Carl Rogers' person-centered approach. And while that is definitely a central part of person-centered care, as we later learned with the research on Carl Rogers' person-centered approach, those are necessary conditions, but they're not sufficient conditions. And I love the quote that we've included here because I think it's really pertinent to our topic today. So I'm going to read the first part of it because I think this is where a lot of us are still kind of living in our practice. In my early professional years, I was asking the question, how can I treat or cure or change this person? And I think a lot of us are still there. Person-centered care really flips that around and starts to get at the second part of his quote, but expands that even further. Now I would phrase the question in this way: how can I provide a relationship which this person may use for his or her own personal growth? And that's really what person-centered principles and person-centered care is all about. It's what can we do as providers do to help identify this individual's strengths, their resilience, their skills, their support systems, their goals, their aspirations, their definitions of recovery, and use those to support them in their own personal growth and their own recovery, journey of recovery. Again, empathy and genuineness are critical, and people, I think, are really good at utilizing those to establish that therapeutic relationship. But then when it comes to the actual interventions and the planning, and sometimes even in the assessment process, we kind of go back to some of our old traditional habits and aren't living out kind of the spirit of person-centered care. So when we think about person-centered care, and this is really important, it's not a style or a type of clinical practice. It's not a specific set of tools. It is a foundation, and from that foundation, all other practices and interventions emerge. And many of the interventions we have do fit nicely with person-centered, but really this has to be our starting place. And it's not just enough for an individual to have that focus, but it needs to be throughout the entire system of practice.
Okay, so person-centered care is really founded on person-centered principles and person-centered values. These principles and values provide guidance on how we can engage in person-centered care as practitioners when working with individuals. And there are a variety of resources available that list the person-centered principles that guide person-centered care. Sometimes resources provide different phrases or words with respect to the person-centered principles, and that said, the person-centered principles tend to fall within 4 overarching person-centered values. And these values are holism, hope, community, and choice. And in this presentation, Julie and I are really going to focus on 6 specific person-centered principles that guide person-centered care. These principles are to treat the individual with dignity and respect, honor and build upon the individual's strengths, skills, and preferences, acknowledge, embrace, and value all aspects of the individual, including their culture, ethnicity, language, gender, sexual orientation, etc. Identify and honor and focus on the individual's desired goals and intended outcomes. Balance what is important to the individual with what is important for the individual, and use a power with as opposed to a power over approach when working with individuals. So it's really important to understand that there are specific principles, values that guide the person-centered care that we engage in or seek to engage in. Okay, so a little bit of information on how we got here. So historically, the term person-centered planning, which is a key feature of person-centered care, was used to describe specific planning approaches for people with developmental disability. In current times, many sectors of care are focusing on person-centered principles and person-centered practices, including the behavioral health workforce. So essentially, person-centered care is not a new concept, but it definitely has received increased attention and conversation in the state of Minnesota since the 2009 Jensen Settlement and the resulting Olmstead Act. So the Jensen Settlement and the Olmstead Act, along with various state and federal rules and regulations, actually require certain practitioners to engage in person-centered care. And DHS has created a helpful protocol called the Person-Centered Informed Choice and Transition Protocol, which describes person-centered practices and who is required to embrace this protocol. You can find the protocol and more information on the requirements regarding person-centered care in the state of Minnesota on the link within this slide. So here is one example of what is included in the person-centered informed choice and transition protocol. This slide and the next slide detail who is required to engage in this protocol in the work that they do. And again, you can find more information on this protocol in the link within the previous slide. I think we can go to the next slide.
So even if you don't find yourself on that list, doesn't mean that you're going to get out of this. So this is an actual quote from the DHS website. Minnesota is moving towards person-centered practices in all areas of service delivery. And I anticipate that we will see policy and licensing rules to follow. So that will be the stick. The carrot right now is that person-centered care even though it's an emerging best practice, initial research suggests that there's better client outcomes, as well as more satisfaction on the part of the person delivering the services. So that's the carrot. Just all around, it's a best practice for everyone. So let's take a look. You're going to advance it for me? We're stuck. A Minnesota roadblock.
All the roadblocks.
Yeah, there we go. Okay. So at its very foundation, person-centered care is a recovery-oriented practice. As Amanda mentioned, it's founded on a central set of principles and values that go hand in hand with a recovery orientation. So not only is this happening within the state of Minnesota, but it's happening at the federal level with SAMHSA, and we were exploring what other states are doing, and they're adopting many of the same principles. So it's a recovery-oriented foundation that is both process and a goal. So recovery is not something that happens after treatment ends. It's something that happens during the process of the treatment experience. In fact, I don't even like the term treatment because it sounds so very passive. We prefer to use the term care, but sometimes that language is a little hard and a little confusing. So we will use them interchangeably, but care is really the preferred term here. So it's both a process and a goal. It's something that happens while they're engaging in their care, and it's very unique to the individual. So it will always depend on the person in front of you, how they define it, what their aspirations are, and what their experience is. And as mentioned before, it's not enough for the individual practitioner to align with that recovery foundation. It has to be infused in the whole system of care with your supervisor, with your team, and with the agency and their practices. Everyone needs that recovery foundation. And again, kind of pulling from Sam's because this is so nicely done, when we look at a recovery foundation, recovery orientation, we're not just talking about the removal of symptoms. We're not just talking about their specific mental health co-occurring or substance use disorder. We're talking about the whole person and the areas of life that they identify that they would like to grow. So it's all the dimensions, these various dimensions of wellness. If you attended some of our other trainings, you've seen this before, but it's because it's a favorite. And what I love about this is that it really sends the message home that recovery is no different for the psychologist or the psychiatrist or the social worker than it is for the individual that we're working with. They want generally the same things out of life as everyone else. They want to not just survive, but they want to thrive as well. And so person-centered care really kind of challenges us and encourages us to move to that next level, not just the symptom removal or of managing those symptoms, but really helping the person become integrated into the community and have a very healthy and full life.
Okay, so is person-centered care really any different than traditional historic treatment interventions? And the answer is yes. The traditional and more historical treatment interventions tend to focus on deficits, seek compliance from individuals. They tend to be controlled or even driven by the professional themselves. They may seek to fit the person and their treatment plan into the program's parameters. And as Julie indicated earlier, they tend to seek stabilization rather than a meaningful quality of life. On the other hand, person-centered care really focuses on strengths, skills, education, providing the individual with choice and options. It's more of a partnership, a shared collaborative decision-making experience between the practitioner and the individual seeking services, where the individual is driving the decision-making process. Similarly, the goals are driven by the individual, and ultimately, person-centered care really seeks to help the individual find a meaningful quality of life.
And as you can imagine, this is going to shake up how we do things in terms of previously we would fit the individual into our system and say, well, this is the group that we have at noon, and this is what we have going on at 2 o'clock, and the individual would just come into that system. And now that's requiring us to change the way we work and change those systems so that we are seeking things that are unique and specific to their needs and not necessarily just fitting them into our existing programming. So this is where the rubber hits the road. How do we shift lanes from traditional to person-centered care? Fortunately, we have the principles to guide us. And the first one is treating people with dignity and respect, going back to good old Carl Rogers. But more specifically, how we can do that is that we need to pay attention to the words that we use and the language that we use to describe the individuals that we work with. The words that do create worlds, and so it's important that we think about how we talk about the individuals we work with, not just with them, but with our colleagues, because that carries over and creates a dynamic with individuals. And so how is it that we talk about them? How does it shape how then we respond to them and work with them, and then in turn, how do they respond to us as a result? So it's a reciprocal relationship, and words very much matter, as we will show you on this next slide. So on this slide, we have a list on the orange side, the unhappy guy side, that are more traditional terminology that we tend to use. So we will refer to people by their diagnosis. It's not unusual, and I hear this, especially as we're talking about opiates, I hear a lot about opiates on the radio, that people will call individuals that have a substance use disorder addict, or we'll hear borderline or schizophrenic. I remember talking with my class saying, well, what would you do to change how you talk about the individual? And one person said, I think I would just call them by their name. I said, exactly, exactly. So let's call them by their name. Let's refer to them that way. Same thing with case. An individual is not a case. Use their name. We hear the term dirty urinalysis a lot. Positive UA. Somebody is manipulative. They're ensuring that they're getting their needs met. They're in denial. We go back to stages of change. They're in they're pre-contemplating change. And if we change resistant to reluctant and cautious, then that leaves the door open for change. And ditto for case manager, we can call them the care coordinator. There's some people that actually, we were talking, we had an advisory council meeting, and somebody on advisory council said, well, why is it that we're even really focusing on person-centered care in mental health and behavioral health? Isn't that a given? We don't ask that about our medical providers. We don't ask that in any other arena. They're already there. And yeah, so as Amanda said before, we do have a ways to go, but changing the way we talk is a huge step forward.
It makes a really big difference. All right, so we're going to spend a little time reading two scenarios or two descriptions of a person, and I'm going to start. So we have Al, who's 48 and has been referred to me or you for outpatient care. His second wife is concerned about him because he has been isolating for weeks at a time, ignoring relationships and hygiene, and expressing grandiose and sometimes paranoid thoughts. His speech is pressured, his mood is volatile, and he sometimes stays up for days on end. He has had similar episodes in the past and has always had difficulty with social interactions, such as maintaining eye contact and reading social cues. He is emotionally detached. He demonstrates compulsive patterns in his eating and dressing. He insists on eating the same exact meal and wearing the same outfit every day, and he has held this pattern for several years. He becomes angry and defensive when confronted and refuses to believe that anything is wrong with him. He has reluctantly agreed to see you or me because his wife has threatened to file for divorce unless he seeks professional help.
So think about what it might be like to work with that individual and how you're feeling about working with that individual. If it were me, my guard would be up. I'd be ready for somebody who's probably going to challenge me and may not want to engage with me. And so I'm getting ready for that. So now let's think about Bert. Bert is a man that is passionate about his ideas and solving complex problems. It's not unusual for him to spend months working intensely and independently on a project. To minimize distractions, he prefers to keep everyday things consistent, such as eating the same meals and wearing the same outfit. Because his projects take priority, he often chooses working on them over sleep or engaging with his wife and family. Bert is also very protective of his projects and ideas. Having a provider that understands what drives Bert will be important to helping him find balance in his well-being, relationships, and sense of drive and commitment. So now think about what it might be like to work with Bert. So if you haven't guessed it already, we were describing Albert Einstein, and those really were some of his behavioral patterns. He liked to wear his wardrobe is exactly the same because he didn't want to have to make decisions about what to wear. He had more important things to think about than that sort of thing. So here we've described to you Albert Einstein, and I think the way we would approach him through our first version is very different than we would approach him through our second version. So our language matters, and I would encourage you all to think about how you can start writing about individuals very differently that conveys more of a sense of hope, optimism, and strength with them, and collaboration. So this brings us to the assessment process. The assessment process from the traditional model is really about mining and identifying problems and dysfunction. And of course, that's very important for diagnosis and for third-party reimbursement, but it also shapes how we respond, where the goal does become kind of the removal or mitigation of the problems, and we miss the client's strengths and resilience. And those things that are kind of the big deal to the individual, which then makes it harder for us to engage with them later on the interventions and setting their goals, and really engaging them in the process of care. Also, what we've noticed too, and this may be your experience, is that assessment can often become a very rote exercise rather than being seen as an opportunity to really get to know the individual, to engage with them, to start to build that supportive partnership and that therapeutic alliance. So we often jump way too quickly into taking action before we really know enough about the individual. So this slide is about slowing down. What do we know? And only once we feel like we've gathered the information, we know this individual, what's important to them, and who they are, should we ask, what do we do? So what do we do really needs to slow down so that we can spend more time thinking about what do we know. And understandably, this is where our systems aren't always as supportive of person-centered care and person-centered approaches. So another key principle that Amanda listed earlier, but I'll reiterate here, is that we acknowledge, embrace, and value all aspects of the individual, including their culture, ethnicity, language, religion, gender, and sexual orientation. So again, this requires a conversation with the individual where you really focus on these sorts of things. It requires exploration, not interrogation, but exploration. How do you identify culturally, racially, ethnically? Who do you include as family? Who do you trust? How does your culture or what does your family say about mental health problems, substance use? How does your family respond to you? What do you call your problem? It's not important in person-centered care that a person identifies with their diagnosis. They don't have to, ever, and they can call it and give it its own name. We don't require that of them anymore. But you ask them, what's it like for you as a Black woman or a Latino, a gay male with mental health and substance use problems? What's that like? And then you invite them to include other people in their care experience. Perhaps it's a member of their faith community, a rabbi, an imam, a priest. You encourage them to invite those individuals in and explore their definition of family and relationships.
A third key person-centered principle is honor and build on the individual's strengths and skills. When we focus on strengths and skills, we are focusing on what is most critical and crucial for the individual. some believe that whatever we focus on grows. So if we focus on success, success may grow. If we focus on problems, problems may grow. An individual may have a hard time identifying their own strengths and skills, and that's when a practitioner can really come in and help them elicit and name their own strengths and skills. So when it comes to an assessment, a strengths-based assessment, it really takes time, and as Julie mentioned, a trusting relationship. It is a reciprocal dialogue, not an interrogation. When exploring strengths and skills, you can explore what has worked for the individual in the past. You can also be creative in the way that you ask questions when exploring strengths and skills. You can ask questions such as, what are you most proud of in your life? What is one thing you would not change about yourself? How would your closest and dearest friend describe you? If an individual names a quote-unquote weakness, think about how that weakness may be a strength. In some settings, an individual may consider themselves stubborn, or are they just persistent? An individual may describe themselves as moody. Maybe they're just transparent. An individual may describe themselves as manipulative, and as Julie indicated to earlier, that individual may just be really good at asking for their needs being met. Okay, this is one example of shifting from a deficit-based to a strengths-based or recovery-based approach to care. So the presenting situation may be a person is not taking their medication as prescribed. From a deficit-based perspective, we may consider that person as lazy or difficult or forgetful. But from a strengths-based approach, we might consider that person as someone who just prefers alternative coping mechanisms. With regards to intervention from a deficit-based approach, we may increase monitoring of medication and use incentives or withholding privileges to increase quote-unquote compliance. From a strengths-based approach with respect to intervention, we may explore why the individual is not taking their medication as prescribed. We may explore other available options and the use of medication as just one of the many very different recovery tools that are available for that individual. You can just take the next one, okay. And this is a nice quote that highlights the importance of getting to know an individual and focusing on their unique strengths and skills. So everybody is a genius, but if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid.
Yeah, and that really highlights that idea of having kind of a set of preconceived set of expectations about an individual, and then again kind of forcing them into our system rather than adapting our ways of working to really highlight their strengths. And this is, Amanda knows, this is one of my favorites. Key principle number 4 is what is in balancing what is important to with what is important for individuals. In traditional systems of care, we've really been focused on what is important for the individual. That is us determining what they need to improve and to get better versus what is it that the individual wants. You know, we assume that recovery means stopping their substance use, reduction in their symptoms of depression. That may not be what is important to the individual. That does not mean that we abdicate what is important for. That means that it's really up to us to connect the dots between what is important to and what is important for. So if we feel, or somebody has expressed that it's really important to them to get a job, and they're not so interested in, coming for care or reducing their substance use, that's where you use your motivational interviewing and highlighting those discrepancies so that the important to, meaning a reduction in their substance use or depression or whatever it is, then becomes important to them, or at least they see the connection between those two. And here's an example just to highlight. The important two are those things that help people, all of us, to be content, happy, comforted, fulfilled, to keep being with people, having things to do that we enjoy, having places to go that we enjoy, the rituals in our lives, having some status, independence, and and things to have. And then really identifying what do they mean by quality of life. And for us, the important four are those things that keep a person safe and healthy and do prevent illness and promote wellness, such as diet, exercise, safe housing, free from fear, substance-free. Those things aren't usually the things that get individuals excited about recovery and about the work of recovery and putting effort and energy into that. It's the things that are important too. But again, it doesn't mean that we give up the important four. It means that we figure out how to connect them. And unfortunately, given the time, I think we're going to have to skip Danny's story. So,
sorry, Danny.
Yeah.
Okay. So in balancing important two and important four go hand in hand with the person-centered principles 5 and 6. Important two is essentially identifying what the individual wants. In other words, what are their goals? What are their intended outcomes? By honoring their goals and their intended outcomes, you are shifting from the traditional power relationship where the practitioner makes the decisions and directs the care to a more collaborative, shared decision-making process that really is driven by the individual seeking services. One misconception is that this means professionals are giving up their role and turning all of their power over to the individual. Or another misconception is that the individual is too sick or too ill to participate in decision making. That's just simply not true. In person-centered care, we seek to identify ways for the individual to be in the driver's seat and really to enhance the collaboration among the individual and their community of support.
So another place where the rubber really hits the road is with person-centered planning is the treatment plan or the care plan for the individual. And you might be thinking about, well, where does all of that fit in? And this is a really critical piece because the treatment plan is the recovery portal. That's how people start to make those changes. And this is where first identifying what is important to the individual comes into play because those important twos become the goals that drive the treatment plan. So we use those goals that they've identified. What do people want? And how can they manage their lives? That is essentially the treatment plan. And the goals provide the sense of purpose, the direction, the motivation, that sense of hope that's so important, and a sense of self-efficacy. So again, the goals are what drive the plan, and the person is what drives the goals. Unfortunately, that is not what is happening largely in practice. So this is a quote, love this quote, that was shared with us by some folks who are considered experts in person-centered planning for mental health. Diane Greeter and Janet, I'm forgetting her last name, from Yale. And they've been working with us for a while. This is a quote from one of their participants. You keep talking about me being in the driver's seat of my treatment and my life when half the time I'm not even in the damn car. I don't know if I should have gotten bleeped for that, but that's the quote. So this is coming from a Yale study. The quote isn't, that's from a participant in another study. But this is the statistics, I think, are pretty alarming here. So of the individuals that they surveyed, 24% reported never having a treatment plan. They did have a treatment plan. They just weren't aware that it existed. Of the 75% that were aware that they had a treatment plan, 50% felt involved only a little or not at all, and 50% were not even offered a copy of their plan. So how do they know what their goals are if they're not even provided with a copy of the plan? Or, as we know, that many times goals are determined from a drop-down menu. So you don't engage, the person's not even with you. You're sitting in a room and you're going from a list, a preconceived list that may not even fit the individual. I remember an example from a student I was working with, and the goal was come to group. Well, and she said, well, the individual is not coming to group, and that's the goal, is to attend group. And I said, well, why is that a goal? That doesn't seem like a goal to me. And I said, what does this person want? Well, the person wants to get their own apartment. Okay, so what does the person need to get to their own apartment? Well, they need to get a job and have an income. Okay, so how does that relate to attending group? Well, coming to group means that you practice those skills of showing up on time, or perhaps dressing appropriately, of social engagement, of contributing, perhaps assuming some leadership. So once you start connecting those dots, then it becomes much more meaningful. So let's take a look at what happens when people are involved. And this is from a 2008 pilot out of Yale. 68%, and this is not specific to person-centered care, but it is about involving people in the goal planning process. 68% increase, there's a 68% increase in competitive employment, a decrease in ER visits, inpatient days, self-harm, harm to others, and a decrease in arrests. And anecdotally, there was an increase in a sense of satisfaction for the individuals that were providing the care. They benefited as well. They enjoyed seeing the success of people achieving their goals. They were able to work more creatively, more collaboratively with others to find successful solutions. They felt more competent. They enjoyed empowering the people that they support, and they experienced fewer disruptions and crises, which is a good thing as well. And they really did enjoy sharing the responsibility of decision-making and resource allocation as well. So all good things.
Okay, so what is a person-centered, recovery-oriented plan? A plan that avoids jargon and is written in a way that the person and their supports can understand. A plan that identifies the person's strengths and incorporates their strengths into the plan. A plan that has a sense of who and what is important to the person. A plan that provides a clear understanding of the purposes and goals of the plan as they relate to the person's hopes, preferences, etc. A plan that details how best to support the person to achieve what's important to that person in a balanced way, and a plan that is designed around personal recovery goals.
You can even use that as a checklist for yourself to see how you're doing.
So what are person-centered goals? Person-centered goals are determined by the individual. They access and use the person's strengths. They seek to connect what is important to the person with what is important for the person. And goals, they can be ambitious. That is okay.
There's a quote that we have here too. It's from Pat Deegan, and she's a psychologist herself who is also someone who has been a patient in the mental health system. People need to have the dignity of risk and the right to fail. So again, that idea that ambitious goals are okay. It's not up to us to say, no, you can't do that. That's not realistic, because who knows what they could accomplish along the way. People surprise us all the time. That's why we do what we do. And even if they don't accomplish that specific goal, the steps that they take along the way, they may find something else. Those are all good things. The other thing we have here are the yes goals, and those are additive goals. So removing something, saying I'm not going to do this, or I'm going to lose weight, or I'm not going to drink, those are not yes goals. Yes goals are something that you're adding to their life rather than taking away. And that's really important because that provides that sense of motivation. So here again, we're just stressing the idea of connecting the dots, and this is your job as the clinician. So when you're you've identified their recovery vision and their long-term goal, then you break it into their shorter-term goals, and the steps, but you need to make sure that those continue to connect to their aspirations and long-term goals, then also keeping in mind that important to and that important for along the way. And the more that you can continue to connect those dots, the more engaged the individual will be with the process. Now, things change. As the person changes, they may change their mind and decide, no, that initial big deal that I told you about, I don't really want to do that anymore. So you need to check in with them frequently. You check into the progress that they're making, the potential barriers that there are, and continue to make sure that it is still important to them. And if it's not, then you switch and you find something else and you go down that track. So maybe you've been having a few of these in your head as we've been going on, the yes buts. And as Amanda mentioned before, one of the yes buts that tends to come with talking about person-centered care is that people will think, well, my clients, individuals I work with are too ill to really engage in person-centered care. So what we want to emphasize here is that person-centered care is a fundamental right of all individuals. It does require you to adapt depending on what setting you're working with and who you're working with. But it also allows you to be creative and to find those ways to engage them in the way that you can and adapt those principles. My clients have no goals. Even the most complex individuals do have goals. They just might not be the goals that you've decided for them. So this is where you're going to want to assess for their stage of change. Many of them feel defeated and have attempted to achieve goals previously with not a lot of success, so they may feel really demoralized. So you want to find little baby steps to help enhance that sense of hope and self-efficacy and use those creative questions that we talked about earlier to establish those goals. Some might say, well, but person-centered planning, it doesn't fit with evidence-based practices. It absolutely does. Again, it should be the foundation of any intervention that you utilize, and it does complement and enhances things such as trauma-informed care. It engages and utilizes motivational interviewing, and as Amanda's going to discuss it, illness management recovery, which many of you may be using already, connects really nicely and is a person-centered practice. And then, of course, some will say, well, person-centered care is just a flavor of the month, so I'm not going to bother changing what I do. It's here, and it's not going away. In fact, Minnesota is moving more intentionally in that direction. So the train has left the station, and it's time to get on board.
So as Julie mentioned earlier, DHS asked us to explore how illness management and recovery fits into person-centered care. IMR was chosen because it is an evidence-based practice that is widely used to support individuals who struggle with mental health concerns. IMR helps people set meaningful goals for themselves. IMR helps people obtain information and learn skills to enhance their own recovery. And IMR helps people maintain focus on and make progress towards their personal recovery goals. So what you see here is a crosswork that we created that shows how both IMR and person-centered planning tools and skills meet the values of person-centered care. Okay. So on my left, you will see IMR, and on my right, you will see person-centered planning. And we didn't necessarily focus on person-centered planning specifically today, but person-centered planning is a fundamental core feature of person-centered care, and person-centered planning is very much happening in the state of Minnesota. So what you see here is the tools and strategies from IMR and person-centered planning that uphold the values that we've been discussing, or that we discussed earlier in this presentation. And you can review the specific tools and strategies at a later time.
So where to next on this person-centered journey? If you're interested, well, as we've mentioned before, the state of Minnesota is moving this direction. They've asked us to create a training on person-centered care, a more in-depth training on person-centered care for behavioral health, mental health providers specifically. And so we're going to be doing that over the next year, and hopefully about a year from now we'll be offering those trainings to individuals in the community. So stay connected with us, and we'll keep you abreast of those developments and when we're launching those. But our colleagues over in ICI also have a number of wonderful trainings on person-centered care. They have 2 levels, sort of an introduction to thinking, and then actually a second level that involves utilizing some tools related to person-centered planning. You can also check out Diane Greeter's book, and we'll, I'm trying to remember the name of it, Amanda, Blanken, Person-Centered Planning for Mental Health, I believe, but if you can check on Amazon, it's available. And so, you know, again, when you see opportunities to get some training or get additional information on person-centered practices, I would encourage you to take advantage of those. So before we bid adieu to you today, we just wanted to leave you with a few tips, things that you can start doing today with the individuals that you work with and with your colleagues. And one is to watch your language, meaning really think about, catch yourself when you're starting to use terms that are not as, have more of a negative connotation rather than a strength or positive connotation. Catch each other in those and encourage, you know, do it in a friendly way, but support each other in really changing how you talk about individuals, because that will change the way you practice, right from a strengths perspective. And think about important 2 and important 4 when you're thinking about the individual and goal setting and making sure that you're really leaning towards that important 2. And I think this is a wonderful exercise when you're having staff meetings and staffing a client, is to really challenge yourselves with each other. Is this important? Are we deciding, or is the individual deciding? And what do we need to do to connect those dots between the 2? Develop the plan with them, have them in the room, and give them a copy of the plan. And then be open to revisions, check in with them, make sure that the important 2 is still important 2. And if not, revise that plan. It should be a dynamic, ongoing process, as is assessment and the treatment planning process. It should be happening throughout the care experience. So before we say thank you, I think we have just about 5 minutes for questions here. Joe, do we have some?
Yes. As a reminder, anyone could submit a question through the chat box below. And with that in mind, we have a 2-part question from Tom. Tom asks, will DHS relax their expectations of a functional assessment and case plan within the first 30 days of opening a targeted case management episode?
So, Tom, you have highlighted one of those systems challenges, and we hear concerns about that a lot. So right now, what an individual really has to do, and unfortunately this does create a little more work for you, is to kind of have your own shadow system. Because I know that they're exploring policy and they're exploring licensing rules. I can't say whether they're going to relax them or not, but I do know that they are keeping planning in mind and starting to do a critical analysis of the barriers that they're actually have been constructed on their end that's making this really difficult to implement. So we hope that over time that our practices and the policies that guide us and the rules and requirements will be compatible and supportive, but we can't say for sure right now. But that is definitely a challenge.
Okay, thank you. And the second part of that question is, how will taking it slow and finding those strengths be operationalized with case management practice?
Well, again, kind of moving, I think especially as we're looking at care and more time unlimited treatment, or looking at care as more of an open-ended process, we won't have those time constraints. And I'm wondering if that's what you're referring to, or if I'm not quite understanding the question. But again, that's a policy change that is, and a licensing change that's going to have to happen through DHS, and I know that they are looking at those. So for now, what I would encourage you to do is get together with your team and your agency and think about creative ways to work within the system that still allows you to be as person-centered as possible. And it's going to require you to be creative, I'm afraid. And potentially, kind of having some shadow systems that go along, which in some ways means more work for you, but if you are more engaged and slowing it down and you're seeing better progress with individuals you're working with, then it actually decreases your work in that way. So more work on the front end may mean less work on the back end.
Okay, and we have one more question from Allison. Allison asks, from a case management perspective, how do we apply these ideas to clients who are obligated to work with us by the courts, i.e. civil commitment?
Right, so they have less freedom of choice, but there is still some choice even within those constraints. And so that's where you really do have to adapt. So they're not going to be able to necessarily experience the freedom and breadth of choice, but you have to find what's going to work with them within that system, and still comply to the requirements. I think, and what I've heard is that some folks within the court system are willing to be a little more flexible, especially when it comes to requirements of abstinence, as long as you can show that the person is making progress and that they are stabilizing and not decompensating, that they're willing to participate and allow a little more freedom and flexibility within that process. So really, I would encourage you to have a conversation with their particular probation officer or whoever it is that they're working with in the system. And you might be surprised that many of them are being exposed to person-centered practices and principles as well, and might be willing to partner with you in working with that individual.
Well, I'd like to thank everyone for joining us. Thank you for those who asked us questions, and I'd like to give a special thanks to Dr. Julie Rehovot and Amanda Talon for sharing their knowledge, skills, and wisdom with us today. If anyone has any further questions, I have posted my email in the chat box, and you can direct them to me, and I will funnel them to Julie and Amanda. Thank everybody.
I have one more, Joe. Sorry, real quick. So the I Spy game, did you notice what it was? Because I'll tell you, it was on me. I misspelled Jessen and, of all things, Samsa. So if you notice those two things, you won the I Spy game. Okay, thanks.
Great. Thank you, everyone. Have a great weekend.
Okay, bye-bye.
Bye now.